Hi guys, my name is Charles and I'm one of the surgeons at Southpaws. Today we have an unusual case for me. I'm sure that there are other people that do tons of them, but I've only probably done a few dozen. And this is a bilateral ventral bulla osteotomy for inflammatory polyps in both middle ears. And so we've done a CT scan and we found a large nasopharyngeal polyp in the nasopharyngeal region, and then there's also fluid within the both tympanic bullas, and so we're going to do a ventral bulla osteotomy. So you can palpate on both sides. Come on, you can palpate on both sides the bulla through the skin, and that's kind of your incision. That's where you're going to direct your incision, and you can keep coming back to that. Just keep palpating that bulla. And that's how you can find your way down into the site. So make our skin incision here. There are a few structures that we will encounter on the way. The linguofacial vein will be lateral to our incision. Can I get my Gelpies next, please? Linguofacial vein will be lateral. You'll see our facial artery. Also lateral, and the hypoglossal nerve will be medial, and probably the most important structure would be that hypoglossal nerve, so we'll want to be really careful to avoid that. Remember that cat bullas have two chambers, and we have to make sure that we get into both chambers, or we'll have recurrence of clinical signs. So, as always, if you're not already subscribed to our channel, please subscribe. If you know anybody else who might be interested in watching this, please send a link to them. And the chat is running, and so if you have any questions, please feel free to ask them. So this is rostral up. Let me see. Rostral is in this direction. Caudal is in this direction, just to get you oriented. And I'm just going to get the camera positioned a little bit better here, so you'll be able to see right down into the bulla. And I think the audio is working because I've got green lights going, but if anybody could please just confirm that they can hear me speaking, that would be terrific. So where is our Metzenbaum scissor? And Gelpi retractors are critical here. You're not going to get away without them. And I just basically just keep dissecting down. There's the linguofacial vein poking out right there. So we'll have to just be aware of that. A little bit of parotid salivary gland sticking out there as well. And I just keep palpating down onto the bulla. And you have to be careful. No, that's fine, thank you. You have to be careful, and I've actually made that mistake in that I'm palpating the ramus, vertical ramus of the mandible. The bulla is actually back in here. So that's the first thing that you need to be aware of, is that you can inadvertently approach the ramus of the mandible instead of the, sorry, I have a cold, instead of the ventral bulla, and so that's something that you want to watch out for as you're making your dissection. So the bulla is actually right back in here. I made that mistake intentionally for you guys, so you know that that's a possibility. That's my story, and I'm sticking with it. So there's the facial artery sitting right there, right in the middle of my incision. Excuse me. And your view might be better on the opposite side. Okay, so now this white structure right here is the tympanic bulla. So I'll just get my freer elevator and dissect down on that a little bit more. Can you see a free elevator, please, or a parastyle elevator? Here we go. Can I get another parastyle elevator, please? So there's my bulla right in here. Let's get my Gelpies in a little bit deeper. Okay, so that's my bulla sitting right in here. Can you retract on that for me, please? Thank you. Eddie, can you look at the screen and see if you can see that, the bulla? Thank you. All right, so that's the nice shiny white bulla right there. Hopefully you'll be able to see that. And again, when we go to the other side, you'll be able to see it even better. And what we're going to do is we're going to use an intramedullary pin to perforate the bulla. And did we get our pins? Yeah, that's fine, thanks. Just lift it up a little bit so when you pull it, yeah. You have to remember that in cats you have the ventromedial and the dorsolateral chambers. And you have to enter both of them, otherwise you'll get recurrence of the polyp. Now, some people, like, you can try to just avulse the polyp from the oral cavity, but you have a very high recurrence rate when you do that. So we wouldn't recommend that as a primary treatment. Let's see if I can zoom in here a little bit more. There we go. It might be a bit too far. There, that's great. All right, so I'm using an IM pin to perforate the bulla. You can see how I've gotten right in there, and then I'm going to use a rongeur to expand my bulla osteotomy. I just use a Lempert rongeur for starters. And this cat presented with middle ear signs, so it had really bad vestibular symptoms. I can see that mostly what's in that bulla is just mucoid material. We may get into more actual polyp as we go a little bit farther in, particularly in the dorsolateral chamber. So now I'm just going to suction out that mucoid material. And it's very difficult to avoid getting Horners in these guys because the sympathetic trunk lies right in the middle of the tympanic bulla, right on that promontory between the ventromedial and dorsolateral chambers. So it's very, very common that you're going to get Horner syndrome in these guys. And it's not, Horner syndrome isn't painful and it doesn't cause any visual deficits or anything like that. So it's not something to be too concerned about. And then we want to make sure that we don't damage the vestibular apparatus by going too far dorsal in our dissection. Okay, so that's all cleaned out. That's the ventral medial chamber. And now I'm going with my pen into the dorsolateral. So you can see I've gone in there. And I'll extend that with my rongeurs. Sorry if my head's in the way. And again, that's more just mucoid material. That's the lining of the tympanic bulla. Right there. I don't know if you can see that being sucked up like that. I'll try to get some of that out with my, let's see, what will I use? Just a curette. And then I'll get a hemostat and see if I can pull that out. It's not as critical as it is with a total ear canal ablation to get all that secretory material out, because total ear canal ablation, you're not retaining the external ear canal, and so there's no place for the drainage to get out. Whereas with a ventral bulla, we are maintaining the external ear canal. And so that means that there's always an exit for any secretions that'll develop later on. So that is the lining that I'm pulling out. And I'm going to be really careful with how far dorsal I go with my suction tip, so I don't damage the vestibular apparatus, which will be in the bottom of that bulla. So I'm pretty happy with the job I've done here. Can we get some saline, please? Did I get that syringe? I thought I did, but I don't know where it's gone. Might have fallen off the table or something. So then we'll just lavage this out. So no tissue. So no tissue within the bulla, it's all just mucoid tissue, and that's probably because of obstruction of the eustachian tube. Can I please get some 4O PDS? I'm sorry, can you repeat that? You're hypotensive?
Yes, sir. I'm on a downward trend.
Okay. And what is the blood pressure?
Currently, systolic is 78 and the map is 59.
Okay, so and you've given boluses. What's the heart rate? Probably give it some atropine first, and if that doesn't work, we can start dopamine. All right, so I'm removing my Galpi retractors. I'll make an effort to close some of the muscular layer. On my way out here. So there's a question about what the approach is on the surgery. So this is somebody that joined us late. This is a ventral bulla osteotomy bilaterally in a cat with an inflammatory polyp. And so we've done a CT scan yesterday, which showed that we had soft tissue filling the bulla on both sides. And there's also a large mass in the nasopharyngeal region. And so we are going to do ventral bulla osteotomies on both sides, get rid of all the soft tissue that's in there, and then go back in the nasopharyngeal region and just pull the polyp out via an oral approach. This is a 7-year-old cat. It's a little bit old for inflammatory polyps, but we certainly can see them at that age. Get you to run this suture for me, please, Ed. I think you've gone underneath the Gelpy. Yep. Actually glad that happened with the mandibular ramus, because that's something that's really common. And so you want to be aware of that when you're making your approach. And luckily we found it after making just the skin incision and a little bit of muscular dissection. Sometimes you're practically all the way down onto the bone and then you realize that that doesn't look like a bulla, and you have to redirect your entire approach. So I caught it early enough that I was able to recover easily. Just watching out for my linguofacial vein. Can I get some 4-O-monosin, please? Just load that up on the other needle drivers, please, Eddie. My linguofacial vein, which is sitting right here, should have been lateral to our incision if I had been going straight down from my bulla, but because I went for the ramus of the mandible, it's come out medial. This is just 4-O PDS, and then I'll switch to 4-O monosin for my intradermal incision. Thank you. The main reason why I'm using monosin is because it's on a cutting needle, and so it makes it easier in cats to do my intradermal incision, my intradermal closure. Yes, please. 2-7 long 30 degree. Thank you, unless they need it for something else. Okay, so just retract on that for me, please. So you can see that it's not too long a procedure as long as you don't get lost. If you get lost, it could be pretty frustrating and daunting. Can you read the other question, please?
How effective is surgery when compared to adult, and also how does beautiful orthotomy practice for such surgery on the past?
So we rarely do ventral bulla osteotomies in dogs, usually because we don't get inflammatory polyps in dogs very frequently. Usually we're doing lateral ear canal ablations and we're doing total ear canal ablations and lateral bulla osteotomies. And so it's a different procedure coming in from the lateral side instead of ventrally. And so when you're doing the lateral bulla osteotomy, you're going to run into different structures like the facial nerve, the internal carotid artery on your way in. And then once you get in there, you have to be much more concerned about the vestibular apparatus because that's just above the opening to the bulla. Whereas in cats, the main structures that we're concerned about are the linguofacial vein, the facial artery, and the hypoglossal nerve. As far as the anesthetic protocol is concerned, what did we use for induction in this, Janine? So we used ACE-meth pre-med, and then we used alfaxan for induction, and then just maintaining an isoflurane. And we are monitoring blood pressure, end-tidal CO2, pulse ox, ECG, temperature, and blood pressure, if I haven't said that already. All right, we'll switch sides. And I can do the left one. Let's grab that stool out of the way, Janine, please. Sorry for my sniffling. Let's see here. Try to move this over a little bit. Leave it where it is. All right, so now coming in on this side, the bulla is sitting right here. So I assume that you can see that. Can I get a blade? All right, so I'll make my skin incision right over the bulla this time, instead of over the ramus of the mandible. Through the platysma muscle, and then I'm palpating down onto my bulla again. Let me get my Gelpi retractors, please. We can see the linguofacial vein. So the facial is out here laterally, and the lingual is medial. And then palpating down again to my bulla. Can I get a Metzenbaum scissor, please? It's our hypoglossal nerve sitting right there. Try not to retract that too much. So that's down onto the bulla right there. You can see I assume you guys can see that big white structure right there. So that's the hypoglossal nerve. And I'm scraping onto the bulla right there.
Another question.
Yeah.
What are the symptoms of the cat when you prognosis?
So the symptoms for this cat were really severe head tilt and just really severe vestibular signs. It had no ear signs and no ear discharge or anything like that. So really just the head tilt. And the prognosis for these is great when you do a ventral bulla osteotomy. If you just avulse it, I think there's about a 60% chance that it'll recur. Sorry, I keep hitting my head on the light. You probably have a better view now of the bulla on this side than you did on the opposite side. So that's a great view sitting right there. Can I get my Freer elevator, please? That's great. Perfect. Thank you. Have I moved my camera? No, all good. And can you see pretty well, Eddie?
Yep. Yeah, I can see it.
I'm going to turn my Gelpies around. Okay. Now you guys should be able to see that bulla really, really clearly. Right there. So that's a really lovely view of that. So just cleaning that off a little bit. Now I'll get my pin. So this is a 1/8 inch pin. And I'm just going to drill, just twirling it with my fingers. And I'm drilling into, and again, this is the ventral medial compartment. And then I'm going to use my Lampert rongeur to expand that osteotomy. Some nice mucoid material. It's a little bit more rust colored, probably a bit more hemorrhage on this side. And we'll just suction all of that out. And I can actually see the polyp on this side really clearly. And I've just suctioned it out. So Eddie, our student, is going to have to go through the suction bucket to find that polyp. So we can submit it for a histopath. Excited about that, Eddie?
Sounds great. Can't wait.
You might have a reprieve here, Eddie, because I think I can get enough of the polyp out for biopsy without you having to go in.
I'm just looking forward to it.
Okay, can we get a biopsy pot? Just grab that suture, that pack of suture there, and I'll just drop the polyp onto that. And we'll hand that off to Janine. Yes. So we'll just hand that off to you and you can... And again, there's less that we can damage in the ventral medial compartment than there is in the dorsal lateral. So I'm just scooping out all of the polypoid material. I can see it actually traveling through the eustachian tube here. So I think that the other side is just mucus in it secondary to the obstruction of the eustachian tube by the inflammatory polyp, whereas this is the one where the polyp actually originated from. So I'm just scraping out all of that polypoid tissue. Some of these cats are going to present with ear signs as well, so ear discharge, usually unilateral. All right, so what are we going to do now? We're going to open up the dorsolateral compartment. And that septum is much thinner than the external wall of the bulla, so that I've already dropped right in there. And this is full of polypoid tissue as well. And sometimes I'll take the lateral wall of the bulla out, and then I'm actually looking into the ear canal, basically. All right, so that is, where's my curette, please? Curette, sorry, the little guy. It's a tiny one. It looks like that. I've been a messy surgeon and thrown something on the back table. And anyway, so now I'm just pulling out all of this polypoid material from the inside of that dorsolateral compartment. Again, staying clear of the dorsal bulla to avoid damaging the vestibular apparatus. Sorry?
Just a question, can you see the CT?
I can try to get you the CT later on. So if I can, I'll probably put individual images up of the CT when I'm finished with surgery, if I have time between this surgery and my next one. A lot of tissue in here. My hemostat, please. Hemostat. If we can't find it, I'll take. Yep. And I can actually put a right angle out through the ear canal. So that's going out into the external ear canal right there. So we'll just flush that out, please. Now that's good. All right. So we are done. Goes back to our glossopharyngeal nerve there. Just be very careful with that when I close. Get back to my 4.0 PDS, please. The purple. Thank you. And I'll take a Adson thumb forcet, please. If got the little guy there. Yep. Thank you. Sorry, I keep hitting my head on the light. Janine, we can start going over post-op. So no antibiotics on this guy. Discontinue the marbofloxacin. Well, who put did the vet put it? Primary care vet. I'm happy to stay on that. Let me get some mitts. Run that suture for me, please.
Yeah, the refit on that.
We'll go ahead and finish that course. So just methadone, and I'm happy for a fentanyl patch as well, please. Yes, it's just a meloxicam, please.
Any other medications that you'd like? He's currently on neuropathy.
Yeah, I think so, just for the vestibular signs.
Continue with IV fluids until leaving.
Yep.
Any other tracking things that you'd like?
Nothing else, thank you.
And sedation if he needs it?
Shouldn't need it. If he needs it, he can have whatever, but he shouldn't. Yeah.
Rechecks.
1 week and 2 weeks, please.
Don't forget to get the
Oral polyp, yeah. We'll have to open up the mouth, Janine, and have a look down there and pull that out.
Do you want to gag?
Sure. And then a spay hook, please. So I'm going to use a mouth gag and a spay hook in order to get a better look down there in the oral cavity to pull the soft palate forward. That's how we'll have a look. I don't think I'll be able to video that. It's just a really hard place to see what's going on. Maybe able to try. We'll have a look. Can I get the Monison, please. Can you let Tegan know that I'm finished in here and to go ahead and get my next patient down?
Yes, she needs theatre for it, so she knows, we were just discussing how far along you were.
Yeah, so I'm basically finished. Thank you. Pull that caudally. So stay tuned, guys. I should have some other surgeries to live stream today. It just depends on where the nurses put me as far as which theater is concerned, because I only have the camera equipment in this one theater. I think that I'm doing an adrenal mass next, a right adrenal mass this time. And if it's coming in here, I will be live streaming that, so that'll probably be in about an hour. Now, right adrenal masses are trickier than left ones because, first off, they're farther cranial in the abdomen, so they're up underneath the liver. And second off, they're right underneath the vena cava. So whereas left adrenal gland tumors are quite lateral and are not underneath the vena cava, right ones are right underneath the vena cava, and often they're a little bit adhered. And so what we do is we get a Satinsky clamp and grab onto the vena cava and elevate it while we dissect the mass from the dorsal surface of the vena cava. So hopefully I'll be able to live stream that. So guys, check your YouTube community posts later on today, because I will definitely try to get the CT scan of this one, and I'll try to take a photo of the polyp in the oral cavity as I pull it out, and then I'll post those onto the community chat or community message board. Pull that, both of those cranially, please, or rostrally. Other rostrally. I've just lost my Aberdeen knot, so I'm just going to put in a, see if I can find the end of my suture here. Could be a hemostat, please. Just a right angle is fine. Grab onto that. Just run that for me, please. Thank you. Hold on to that. Get release. All righty, so that's it, guys. Any questions, post them on the message board. Thanks again for watching. Don't forget to subscribe to our channel, and I will see you later on today, hopefully.